Hello everyone, my name is JD Russo and today I will be presenting blood flow restriction and its effects on hypertrophy. So just to give a brief overview of what I'm going to be covering today, I'm going to go over what is blood flow restriction, or also known as BFR, how it can be used for hypertrophy training, the reason why it is used, the proper procedures for using BFR and any safety concerns that are brought up, who can utilize BFR. So, is there any special population, whether, it's only beneficial for the athletic realm or the general population, or both? And then I'm going to go over a brief overview of my study design. So, what is the difference? So, in order for an individual to show any muscular hypertrophy, the American College of Sports and Medicine recommends, has a few recommendations. So for intermediate or novice lifters, they recommend doing between 1 to 3 sets of 8 to 12 repetitions, ranging between 70 and 85% of their 1 rep max. For a little bit more advanced individuals, they should perform 3 to 6 sets of 1 to 12 repetitions, anywhere between 70% and above of their 1 RM. Now, depending on the intensity of the exercise is going to dictate your rest level. So for a little bit higher intensity, you should rest anywhere between 2 to 3 minutes between sets, and for lower intensity, anywhere between 1 to 2 minutes. So Yasuda et al. In 2011 stated that the best way to undergo muscle hypertrophy is by high-intensity resistance training. Recently in the exercise science community, new research has been conducted where performing low-intensity resistance exercise while utilizing BFR can elicit similar hypertrophic values as those adhering to a high-intensity resistance training protocol. Now, BFR, this is where the individual is going to perform anywhere between 20 to 30% of their 1 RM. Typically, throughout the literature, you're going to see 4 sets of 75 total reps. The rep scheme is going to be split up as the first set's going to be 30 reps, and then the remaining sets are all going to have 15 repetitions in them. The rest interval is typically going to be a lot shorter than what you would normally see. So 30 seconds rest. And the reason behind this is to increase the amount of metabolites that are being produced while undergoing hypertrophy training. Now, when you use BFR, you would place a cuff, whether it's made out of nylon or elastic, around the limb, and then you would go through the resistance training protocol. So BFR dates back to the 1960s by Yoshiaki Sato, who originally coined the protocol as KATSU, K-A-A-T-S-U. A lot of research out there, for example, Springer et al. In 2015 and Vane et al. In 2017 mention him as, he was the one to really start everything. So blood flow restriction, as you know, obviously you're restricting oxygen to the muscles, so there's going to be a buildup of metabolites. Now, in theory, this can increase your type 2 fiber recruitment through type 3 and type 4 muscle afferents. Those type 3 and type 4 muscle afferents will then inhibit the alpha motor neuron, which supplies the type 1 fibers, as stated by Leniecki et al. In 2012, as well as Springer et al. In 2015. Now, we all know that in theory, things may work, but how is it going to turn into a practical setting? So just because it works in a lab doesn't necessarily mean it's going to work in a real-world setting. So this theoretically is the impacts that blood flow restriction training can have with light-intensity resistance exercise. As you can see, it's going to increase hormonal factors as well as transcriptional factors, such as upregulating mTOR pathway, VGF, increased muscle protein synthesis, and so forth. It's also going to have a positive effect on your cardiovascular response, so it's still going to stimulate things like that. And as you can see from the table, as stated in Park et al.'s study in 2015, kind of get a brief overview of what all is going on during that protocol. So there has been a lot of debate about the pressure in which the cuff should be set at. Leniecki and colleagues in 2013 stated that the pressure should be high enough to occlude venous blood flow from the muscle, but also low enough to maintain arterial inflow into the muscle. So just enough where you're blocking blocking that blood supply, but at the same time, not causing any detrimental effects. There has been debate whether you should set the cuff pressure high or a little bit lower. In 2010, Fry and colleagues conducted a study with elderly men where the cuff pressure was set at 200 millimeters of mercury. And then on the opposite side, you have Nielsen and colleagues who conducted a study in 2012 with young males where the cuff pressure was set at 100 millimeters of mercury. So a lot of room for a lot of wiggle room there. So which one is exactly better than the other? And obviously, with restricting blood flow, there are some safety concerns, such as causing, or those who have high blood pressure, hypertension, as stated by Lanek et al. In 2012. So the whole purpose of the study is to identify what is occurring mechanistically that's going to elicit your hypertrophic response in the skeletal muscle while utilizing BFR in conjunction with low-intensity resistance training. Then we're going to discuss an ideal protocol to use. So evidence does show that when in conjunction, these two things should elicit hypertrophy. So once again, we're not really sure if it's going to carry over to the real world setting, but it has been shown that it can benefit all the population. So whether it's athletes, those who are a little bit older, so the elderly population, and also those who are recovering from an injury. So if an athlete gets injured, not able to compete and things like that, not able to train, they can utilize this so that way either maximize their recovery process or minimize the amount of strength and muscle lost while they're still recovering from their injury. So just to go over some limitations and delimitations of the study. So limitation of the study would include the adherence of the training protocol, whether the subjects are going to drop out of the study due to the time constraint, or they're just not motivated to continue. The sample size is also going to be a limitation. So the smaller the sample size, not going to be able to generalize it for a population. And also the pressure of the cuff, which is probably going to be the most major one. So what the pressure is set at, what the initial pressure is set at, and so on and so forth. The delimitations would be using trained individuals. The reason I'm not using trained individuals is that with those trained individuals, you're probably not going to see as much of an increase in hypertrophy or strength for that matter, just because they are trained and they already are used to the stimulus. Rather, you would use untrained individuals, so that way you could see more of a hypertrophic response. And also, I'm not going to, really use a shorter duration study, so I would recommend anywhere a little bit over 4 weeks, simply because you're really not going to see any physiological benefit from anything less than 4 weeks. So what does the literature say? So once again, by stated from the ACSM, lifting any below 70% of your 1RM doesn't really promote significant muscle growth. Now in 2010, Schofield basically explains that in order to gain hypertrophy, there must be a metabolic stress placed upon the body. So this is going to cause satellite cells to proliferate in response to that stress, so an upregulation of mRNA, which should increase your cell growth. Now, Park and his colleagues stated that low-intensity resistance training and in conjunction with blood flow restriction does elicit some similar physiological responses to those partaking in high-intensity resistance training, and his study was conducted in 2015. And there were similar findings in other research that I came across, such as Lanek et al. In 2012, which states that low-intensity resistance exercise in conjunction with BFR does increase muscle protein synthesis and other transcription factors. So the benefits of BFR on the mTOR pathway. So we know that the mTOR pathway basically is the master network for promoting skeletal muscle cell hypertrophy. With that, there's going to be an influx of signals that are going to be sent in a downstream fashion. So when that metabolic stress is placed upon the body, you're going to see an upregulation of certain things. Now, a theory behind why BFR does promote this is first introduced by Hossinger et al. And colleagues in 1993, which Linek et al. In 2012 stated in his research that when BFR is applied, there's a shift in intracellular and extracellular fluids. Now, this shift is going to cause an upregulation of the mTOR pathway by rapid influx of blood flow once the cuff is taken off. So, rapid influx of blood, more nutrients supplied to the muscles. So again, in theory, it should elicit hypertrophy. And this is just basically a picture stating the swelling cell theory. So as we can see, with venous blood flow restriction and exercise, there's going to be an influx of water, which is then going to upregulate the mTOR pathway, which then should increase muscle protein synthesis. So in 2012, Kim and colleagues conducted a study utilizing BFR on young males. So there were 30 participants. The study was about 3 weeks long. They did resistance training about 3 times per week, but they did not follow the typical rep scheme that you would typically see in the literature that I came across. Instead, they did 2 sets of 10 reps for both the high intensity and the low intensity BFR group. And the exercises that were utilized were the leg press, leg extension, and the leg curl. Now, 1RM testing was done pre and post to see any increases. The cuff pressure was set, the initial pressure was set at 50 millimeters of mercury, and then increased to gain the full occlusion of blood flow. Muscle biopsies and blood samples were taken to analyze cross-sectional area and serum levels. And overall, the high-intensity resistance training group showed a greater increase in cross-sectional area. Now, some problems may be, they didn't perform enough reps in the low-intensity group to see any increase in CSA or serum levels of growth hormone. Another one, the study was only 3 weeks, so typically on the shorter side. And with this, it's either hit or miss whether you're going to see increases in hypertrophy or not. Now to go on to another study, Elefson and colleagues conducted a study in 2015, which they utilized lower intensity resistance training and BFR on young females. So in this, they wanted to look at serum growth hormone levels, 1RM of the knee extension and cross-sectional area of distal parts of the quad. So they had 9 females around 22 years of age. It was a 12-week study where they trained 2 times per week. And the 1RM was tested 3 times, so that way they would kind of adjust while they were going through this protocol. So 1RM was taken at baseline, 6 weeks, and then at the conclusion of the study. For the first 6 weeks, the pressure of the cuff was set to 90 millimeters of mercury, and during the second half of the study, the pressure was set to 100 millimeters of mercury. Overall, they didn't really find any statistical significance between the two. 1RM and cross-sectional area were more pronounced in the high-intensity resistance training group. But overall, their growth hormone levels were pretty much similar in both. So kind of, teeter-tottering back and forth to determine which one was more beneficial or not. So overall, throughout the literature, there really isn't any cookie-cutter plan. There's really not a consistent protocol used. There's no really common pressure, as you can see from the different studies. That's ranging, a little bit higher, a little bit lower. So a few studies that state that standardized pressure isn't really seen throughout the literature. Jess et al. In 2016 stated that, as well as Linek et al. In 2013 and Sprenger et al. In 2015. So consistently throughout the literature, there isn't a common pressure set. And there really isn't a common protocol use, although there are common rep schemes seen, but not all studies do utilize these things. So my study design is going to cover a little bit of both demographics. So I wanted to test, the difference with resistance training. So I'm going to have two groups, four groups really. Two groups of young males ranging, between the ages of 21 and 25. So you're going to have a low intensity resistance training group with blood flow restriction, about 10 participants, and then a high resistance or high intensity resistance training group. Same goes for the older population, so that way you can see if there are any differences between age, any age discrepancies. Through my study, I'm going to use untrained individuals, so the qualifications, they can't train for 6 months prior before the study. They don't have any health complications, things like hypertension and so on and so forth, and they were given consent forms to fill out, and we're told the risks of the study. So for the procedures, like I said, there's going to be 4 total groups, 2 for the low intensity resistance training with blood flow restriction, and 2 of the high intensity resistance training. At the beginning, body mass was calculated and BMI was calculated using a bod pod. So they were going to undergo an 8-week resistance training protocol where they trained 3 times per week, so a Monday, Wednesday, Friday split, doing 3 exercises, so the leg press, leg extension, and the leg curl. The reason why I did 3 weeks was because 2 weeks I felt like wasn't enough. However, training for 8 weeks, 3 times per week with untrained individuals, you do run the risk of overtraining. But we'll see how it goes and things of that nature. So for the training protocol, 1 RM was taken 3 days prior to the training, as stated by the ACSM in 2013 that if you're going to do any 1 RM testing, it should be at least 24 hours before the testing to allow for recovery. And then 1 RM was going to be tested at baseline at week 4, so about halfway through the study, and then at the conclusion of the study, so week 8. Muscle biopsies were also going to be taken. So those were going to be taken at baseline and then 8 hours after the conclusion of the training session. And what we're going to look for in these muscle biopsies for a shift in fiber type, so type 1 fibers, type 2 fibers, and the satellite cell content. So before each training session, the participants are going to do a 5-minute warm-up on the treadmill, just to get the blood flowing and things of that nature. And then they're going to go split off into their respective groups. So for the low intensity training with BFR, they're going to do about 4 sets, following the 75 rep scheme of a 30, 15, 15, 15 split at 20% of their 1 RM, where they're going to take 30 seconds of rest in between each exercise. The high intensity resistance training group is going to do 4 sets of 5 reps at 75% of their 1 RM, where their rest interval is going to be between 1 to 2 minutes. Now the instruments being applied, throughout the study I did see that the KATSU device was a little bit more standardized in a way. You do have the ability to display the initial pressure before the inflating, which is going to be set to 50 millimeters of mercury in this study. And then in order to gain that occlusion of venous blood flow, the pressure is going to be increased in increments of 20 millimeters. So it's going to be placed around each leg at the most proximal point. And the reason for adjusting the pressure is that people have different limb sizes and things of that nature. So one person might take a little bit more blood or a little bit more pressure to gain that full occlusion of blood flow, while others don't take as much. The biopsies were taken using a 5-millimeter biopsy needle. Local anesthesia was applied, and it was taken between the same area, the same depth, about 3 centimeters apart. Once obtained, they were stored at negative 80 degrees Celsius using liquid nitrogen, and then cut and placed onto glass slides and stained with a buffering solution to analyze for fiber type and satellite cell content under a light microscope. Now when computing the stats, it was calculated and expressed by means using standard deviation. So for the 1 RM and muscle biopsies, ANOVA testing was used. Post hoc test was used with Bonferroni when appropriate, and the significance level was dictated by p-value that is less than or equal to 0.05. So at the conclusion, overall, throughout a lot of meta-analyses and literature that I read, these studies do show that low-intensity exercise, low-intensity resistance training in conjunction with BFR is beneficial. It can be beneficial for the athletes as well as the non-athletic population, such as the elderly battling sarcopenia and things of that, as stated, by Bagley et al. In 2015, Yasuda et al. In 2015, and Sleisenberg in 2016. So overall, BFR training is good in conjunction with low-intensity resistance training, but more studies do need to be conducted in order to find a set procedure and protocol to follow. And these are my references. Thank you.